Well, hello and welcome again to Medical Mastery, the podcast of the Emerald Coast Medical Association. We are very happy to have you here, and we're very happy and pleased to have Dr. Christopher Johnson here, a friend, a surgeon, Emerald Coast Medical Association member, father, and all things possible, I think. So, Chris, welcome here today, and
thank you, Donnie.
Thanks for being here.
Of course.
So, part of this is that we want to get an idea for our membership about who our members are, kind of their tale of the tape, their specialty, kind of what the insight that they bring, and just talk about various different things that you think affect your practice and your life and the community around us. But starting off, tell us about where you're from.
Yeah. So I actually grew up down the road in Crestview.
I've heard of it.
There's a dusty high school, Crestview High School diploma in a box somewhere. I grew up there, and then left when I was 18. Went to college at LSU.
I've heard of it.
It's
Go Tigers.
Yes. Go Tigers. And spent 4 years in Baton Rouge, getting my undergraduate degree in music, which is a whole story into itself.
Wow, fascinating, yeah.
But it was great. I had a great time in college. And, was in the marching band at LSU and got to experience all of that. Minored in chemistry and biology because I realized I was a whole hell of a lot better at organic chemistry than I was at the bassoon.
It's not too many bassoon players,
right?
There,
right.
So,
it's a small group. There were actually two in my year. Myself and another girl were the only two bassoonists in our year. She is now teaching bassoon orchestra.
Okay, all right.
I'm a physician.
Well, you were in the top two.
Yeah, right.
That's good.
But no, it was a great time, and I realized I wasn't going to be an orchestra conductor, and decided to get my chemistry and biology minors. Actually came back over here to watch a surgeon in Crestview take out a gallbladder, and said, "That's the coolest thing I've ever seen. I want to do that." And it was kind of changed things midstream, and pivoted, not away from music, but had to get a little more science prereqs, and then ended up applying to medical school and got in at Florida State. So came back over to Tallahassee for 2 years, and then Pensacola for 2 years of rotations, which was great. And because I really enjoy the drive on I-10 between here and Louisiana.
Been on that one several times, yes.
Went back to LSU in New Orleans for residency.
Yes.
For 5 years in general surgery. And then I did a 1-year fellowship in Baton Rouge in advanced GI, minimally invasive surgery.
Okay. A lot to unpack there. We're going to take a step back here. So you have the mind of a musician, which tends to be more artistry. Do you think that there was some crossover there that kind of led you towards a more scientific analytic background? Because those are kind of two different worlds.
So there, absolutely. And I think there's a lot of preconceived notions about a lot of things. And those preconceived notions are generally made by people who have no idea of what they're notioning about, right?
You're speaking to one right now, isn't it? Okay, go ahead.
So there's this notion that musicians are these either troubled musicians, or I'm going to be a starving artist, or things of that nature, and that these scientists are these hardcore empiricists and things like that. And what I have found, kind of straddling those two worlds, is number one, and this is not very well known, there are actually a lot of physicians that are musicians. Yes. Boston actually has a orchestra that is made solely to enter into the orchestra. You have to work in the medical field.
Oh, very cool.
And there's a lot of crossover there. I often would tell my students, I work a lot with students wanting to go to medical school or in medical school. I'll tell them, listen, the two approaches, or sorry, the two the surgeon and the musician.
Yes.
When they're coming out of their various theaters, which I love a good dad pun, neither of them are satisfied.
Yes.
And that the surgeons and the musicians that I respect the most and that I try to emulate the most are the ones that are never satisfied.
Yes.
They go in and you may have a very good outcome, patient may do well, but they're always saying, how can I do this a little bit better? How can I be a little more efficient?
Right.
The same thing with music. I mean, one of the things in music, when I was in music school, we were just transitioning over to a lot of digital recording and things of that nature. I remember saving up money to buy a digital recorder so that I could play things back and actually hear myself and critique and go over things. I do the same thing now. I video all of my surgeries, and it's like game tape.
Yes.
And so that attention to detail approach of spending 4, 5, 6 hours in a practice room on a Saturday to learn the nuances of why this note is there, why that note is there, and to elevate your performance just that little bit more, it's applied to the nth degree in surgery.
Man, I love this because it's almost like there's a platonic ideal of a surgical procedure that you are constantly trying to strive to, and you can asymptotically approach, but you can never actually get that.
Right.
And it just requires iteration every single time and constant self-improvement, which is really, it's great to hear because that also means that you're curious about these things and constantly trying to do that. The other thing is, I've heard the contrapositive saying in surgery, which is that perfect is the enemy of good.
Right. And
so,
that is, I think that to I have a lot of attendings in the back of my head saying that every so often.
They're always over your shoulder watching.
Exactly.
Yes.
And that's where the clinical time, the old adage, if you learn more in the first 5 years of practice than you do in all of residency, that's where that comes in.
Yeah.
Is knowing, not necessarily what's good enough, but where perfect will actually cause harm.
Yes.
And that's hard. It's very difficult because it's not in my world. It's not just, I could not technically perform this operation. I may be able to technically perform this operation.
Of course.
It's the speaking with the patient, speaking with the family afterwards, saying, while I could technically perform this operation, I am not going to improve your quality or quantity of life in order to do that. Yes, I could do this big procedure, and yes, I could get you off the table, but I'm not going to elevate your experience of this world by doing so. And that's hard.
It is. Yeah. It is hard. Are you going to benefit at all from this? This is a really great thought process. And this is something that I say to the medical students that I get to have, which is that, there's a saying from Sir William Osler, the father of internal medicine, which says that the young physician has 20 treatments for every ailment, and the old physician has 1 treatment for 20 ailments.
Yes.
You can be wise about things, and just because we can do things doesn't mean that we necessarily should. Right. And so this is part and parcel with one of the things that I think about you and your wife, as a matter of fact, which is one of the higher compliments I can give, which is I think you are a very good doctor. Now, that means to me, not that you are a skilled surgeon or a technician of some type, which you are, it's that you're going to do the right thing for the right patient at the right time. Right. And that's really one of the things that I want to inculcate into our medical students.
Yes.
This is really, and that also kind of jives with the arts, back to the music side. We really do have to combine art and science a little bit here. And that's a constant thing that we're doing virtually every interaction, I think.
Oh, 1,000%. The saying in surgery is, it takes 10 years to learn how to operate, 10 years to learn when to operate, and 10 years to learn when not to operate.
Yes.
And that last part's the hard thing.
Yes, it is.
And I tell students all the time, you can teach a monkey how to operate. I'm evidence of that.
Yes.
But a good surgeon is the baseline, the understanding, the most minimal thing is a good technician.
Yeah.
If you are not a good technician, you can't aspire to those higher things, right?
That's right.
And so yes, you have that technically perfect. That is everybody else in the room has that.
That's the bare minimum.
That's the absolute bottom of the barrel.
Yeah,
and
that's right.
And that in order for that to be the bottom of the barrel, the amount of time, effort, and blood and sweat and tears that goes into that really gives, when I'm talking to other surgeons that have been doing this a long time, it really puts into perspective, wow, this person has not only done this incredibly difficult thing, but they have then taken it to the nth degree. Mm-hmm. you know, and just to back to your art in every every interaction. I tell my students all the time, because they'll be, would be between patient cases, they'll be like doing questions, getting ready for a test, and I will tell them, stop worrying about the test. Like you get good grades. Like you can take a test. That's how you got here.
Yes.
Again, back to the bottom of the barrel. That's the baseline.
Yes.
Your test is not going to be the paper test, right? You're never going to get away from that, and you should do well in that.
Yes.
The test is in the patient room. The test is the performance, right? The performance of being able to have just told one patient that they have an inoperable disease and being with that family, and then doing the news anchor performance practice of there were 4 bodies found at the scene today in eggs, right? Like just look through a different camera.
Yes.
And it's that performance, the art of being able to say, hey, I dropped this note, I need to move on.
That's right. That's right. And cordoning off those kind of emotional abilities throughout your day, where you really want to empathize with people. You want to empathize with their families. You want to understand. You want them to understand that you feel that they are going through this suffering, and you want to try and help them out of a place that they're not comfortable. But you also have to be ready to do the next procedure too.
Yeah.
And see the next hot gallbladder that comes by your way. You got to be ready for that. So, I want to go back just a little bit, because you are not the first person in medicine in your family. Is that correct?
That's correct.
Okay.
Yes.
You want to tell us a little bit more about your family?
Yes, my family. I love my family. My dad got a lot smarter when I moved out of the house. Put it that way.
My dad said he and my brother became friends after he moved out of the house. So.
And my dad and I are friends. We talk nearly every day.
Yes.
And my dad's a primary care physician in Crestview.
Yes.
Has been there, how old am I? 37 years. Started out there, small town country doc, joined 3 other guys. Yeah. And what does it say? Back when men were men and giants walked the earth.
Yes.
He did
the earth was hotter then. Who knows?
Right.
Yes.
He did a 3-year family medicine residency. Okay. And out of that 3-year family medicine residency, when he began working, was running a primary care clinic, worked in the ER, delivered babies, did his own central lines, and did ICU care, did all of this. This was
I hate to date your dad on this, but it's so impressive. The old school guys, just their clinical acumen, their ability to just do everything. And when you ask them about it, they're kind of aw shucks about it. Well, yeah, to put a central line. Nobody else is going to do it. I do it.
Me.
Like, yeah, exactly. So, of course, I'm going to deliver babies.
He's been in Crestview for 37 years and does the whole gambit of what family practice is. And he's my dad's a humble guy, but he's a proud family practitioner. Mm-hmm. He will be the first to tell you that he has no idea what I do. I asked him one time, because he did 6 months of surgery in residency.
Oh.
I asked him, could you take out an appendix if you needed to? Could you fix a hernia if you needed to?
Yes.
He's like, I wouldn't be happy about it, but I know what you're talking about.
Yes.
But I'm not going to even pretend that I, can do this. So, but no, he's a great guy. He's been my dad is a Renaissance man.
Yes.
And I think was a huge influence on me. He went to medical school, has a zoology degree.
As you do.
Played viola in orchestra. Plays a little violin now. And also, is a great family practitioner, but I've helped him rebuild a tractor engine.
Man, a true polymath, huh?
Yes,
right? just wants to know how things work and fix it. Yeah.
It really, we joke about it now, but I distinctly remember him, looking at something and saying, well, I could hire somebody to do that, but that costs money. And money doesn't grow on trees, and I can figure this out.
Yes.
So we've done all sorts of stuff. We've built a septic tank for the laundry room. We built boat lifts. He was teaching me how to weld when I was younger. We've resided the house. These are skills that I had the privilege of seeing someone with letters behind their name.
Yes.
That is respected in the community, not afraid to get very dirty and, get the smell of the sheep on them, if you will.
I think that primary care is, God's honest truth, one of the hardest specialties right now.
Absolutely.
It is so difficult to be able to navigate this healthcare landscape nowadays. Yes. Insurance companies, everything else notwithstanding. Just the ability to know how to coordinate these patients, make sure that they're screened appropriately. We need a lot more primary cares. We need a lot more people that are going to have the clinical acumen and the ability to understand when people need something and when they don't. And so I really respect our primary cares quite a bit.
I do as well. I asked my dad one time, what do you need to do to be a good primary care doctor, right? Because I'm a surgeon. I'm a fancy plumber. I've got to make sure the pipes don't leak.
Yes.
Right. And so there's a relatively short list of things that I need to do extraordinarily well to be a good surgeon.
Yes.
But to be a good primary care doctor, what do you need? And I was expecting, this was a number of years ago, I was still early on in my residency training. And I was expecting to hear, I really want a good A1C.
Yeah.
Which, foolish me, why would a good doctor just want a surrogate marker for that? We won't get into surrogate markers.
Yes, no, we can if we need to, but yes.
It was youthful of me. But what he said was, I've got to be able to find the things that are scary in a sea of normal. In
Signal
30
noise.
patients a day, all of whom complain of chest pain.
That's right.
Who's having the heart attack?
Yeah.
And I go, well, how do you do that? He goes, it's really hard. But I remember, and he probably doesn't remember this particular story, but I remember him calling me one time. I think it was about the same time, and being really excited because he caught a stroke, in his clinic.
Yes.
In a patient that had some underlying movement disorders. I feel like Parkinson's or something like that.
Yes.
And he picked up, hey, this is not different. And that's one of the things the long continuity of care. He's seen this patient for 20 years. 20 years. He's seen this person, he knows them, and he knew something was off.
Yes.
That's the art of the primary care doctor.
And
right?
that relationship that you establish where you do know this isn't them. And this is something
they may
different.
not be quote unquote normal.
Of course.
But
of course.
This isn't them.
Who is amongst us?
And I remember him being very, very excited about that. I got him over to the hospital and we got him taken care of. So
yeah. Well, so sounds like a good model for how to be kind of a long stalwart physician in the community and helping out, which certainly seems what he's done for a number of decades
and
now.
Continues to
do. Yes. So now let's go back to your training just a little bit. Okay. So 5 years surgery residency, as you do, standard. This is at LSU in New Orleans.
Correct.
So can you tell us maybe a little bit about the pathology that you're getting at New Orleans and perhaps how that could have been formative to your training?
Absolutely. So I would suspect people in this area, the ECMA membership, to know New Orleans relatively well. And if you haven't been to New Orleans, I know you have, but if members haven't gone,
it's an experience.
Go.
Yes,
just go. It's an old city. It's wonderfully old. It feels lived in a good way.
I told you, it's not an American, it's not a European city, it's something in between. Yes,
it is the northernmost city of the Caribbean, and I love it. But the surgery program in New Orleans is a very unique one. It's a very old one. We, at one point, I think we're the second or third largest program per residents in the country.
Yes.
We treat a lot of residents there.
Yes.
And when I was looking at places to go, a compelling factor was I wanted to operate. I wanted, the name of the course is surgery. I wanted to do surgery. And there are a number of surgical training programs in which you never see the operating room until farther along. Mm-hmm. And there's reasons for that. However, LSU is not wholly unique. There are a number of programs that have a early operative experience model, but fewer and fewer.
Yes.
And so that was, I went there for an away rotation, and the second year was working on getting into and closing the abdomen, and I was like, this is it.
Yeah, this is my jam.
But the program itself, for a long time, provided the workforce for the charity hospital system in the state of Louisiana.
Yes.
And so because of that, we went to a lot of different cities. When I was there, we went to Lafayette, Baton Rouge, and New Orleans. We used to go to Lake Charles before Hurricane Katrina.
West, I'm sorry. Mm-hmm.
But the surgical pathology you see in those different places are wholly unique.
These are perhaps extremely rural areas where you're going to get people that do not follow very much. So the downstream of that whole thing is you're going to get pretty deep stage pathology by the time it comes to you. It's going to be a mess by the time it comes into the surgeon's office.
If you want to learn how to perform a Whipple procedure with baling wire and duct tape, you go to Lafayette, Louisiana, to the University Medical System, and you do it because I've done it.
Well, it turns out I don't. But either way, it's good to know that somebody's out there doing that.
And they're great people out there. When I was in I didn't finish training that long ago, but the patients know you're their doctor, even as the resident.
Yes.
You have a patient happy you fixed their inguinal hernia and leave you a sack of crawfish in the bed of your truck. This actually happens,
yes.
and I wish I was making it up, but
of course
it's wild.
Yes, I had the patients that would say to the attendings, as long as it's okay with my doctor. To the fellow.
Right, yes,
yeah, exactly.
Exactly.
Okay.
But no, New Orleans, in the city, you get a lot of your inner city knife and gun club, trauma, things of that nature. Baton Rouge, we operate at 17 different hospitals and surgery centers. So the main hospital in Baton Rouge we worked at, and where I actually did fellowship, it's the largest hospital in the state of Louisiana. When I was there, it was 600 plus beds. I mean, you name it, we saw it.
Yes.
We were the quaternary referral center for the area, and one of the things that really interested me, and it's part of the reason that Allie and I decided to come here, part of what I did my research on, is if you are a waitress in Bunkie, Louisiana.
Yes.
Which someone told me one time, I asked them, they said they were from Bunkie. I was like, oh, I've been to Bunkie. They looked at me and go, you hadn't been from Bunkie. I'm from Bunkie and I've never been from Bunkie.
Exactly.
These are really small
This is
communities.
a small place, yes.
If you're a waitress in Bunkie, you can barely afford to get to Baton Rouge, much less go to MD Anderson.
Of course.
Right? Or the Mayo Clinic or wherever. And a number of my attendings, specifically a guy named John Lyons, and JJ Tabor, were really passionate about being able to provide absolutely world-class care, like the same as MD Anderson, the same as the Mayo Clinic, to these people who are on the margins and not marginalized for whatever reason.
Right.
Folks who are getting by day to day, who have a real problem, who can't afford to get.
They won't understand the quality that they got.
Right.
Out
never.
of that.
Absolutely
They'll never
never.
understand
No.
that, and it's still worth your while to do it.
Oh,
That's a great altruistic goal. Yes.
And it's been interesting here. We'll get back to Louisiana in a second, but it's been interesting speaking to some of the patient population here, because as I've learned over the last 4 years, we're 5 hours from everything.
Ain't it a geographical oddity?
We are the hub of a spoke,
Yes.
and everything's 5 hours, right?
Yes.
Mobile, UAB, Emory, Shanes,
Yes.
Mayo. And so a lot of people, if you have the money and the wherewithal, and with the cell phone, you can find, there's Dr. So-and-so at Shands or Mayo. And that works for a lot of people.
Yes.
If you're able to have a $3 million beach house and or a penthouse out on the beach, you can do that. If you clean the penthouse on the beach, I believe your worth is the exact same as the person that owns the penthouse. And while for certain things, it is better to have care at a quaternary center. I still refer to quaternary centers.
Of course.
Tertiary centers.
Of course.
That bar, part of what I saw in Baton Rouge and with those guys at Arlington Lake was to take that bar and lower it.
Yes.
Right?
Yes.
Hey, you and that's been the history of medicine, right?
Yes.
when robotic surgery was in its infancy, you had to travel to the university centers.
Yes.
Right? And actually, that's not the case. That's a bad example because minimally invasive surgery actually came from the private side of things.
But the first heart transplant,
right?
The first heart transplant,
yes.
that's done in one center, and now we have a multitude of centers throughout the nation. Yes.
And so you're democratizing care.
Yes.
Excuse me.
That's right.
You're democratizing care. You're making care easier.
Yes.
I'm going to cough real quick. Hang on just a second.
And so you certainly are getting the care that's, to paraphrase you, that people deserve, regardless of their class, their status, whatever.
Right.
And, when you talk about that training in Louisiana, that's Cancer Alley too.
Oh,
so
yeah.
you're going to see all different kinds of, again, deeper pathologies. Right. And I really, little history about New Orleans and its surgical programs, the Charity Hospital, that is, I think, one of the few, it's no longer in operation, but as of not long ago, it was still in operation, still had an open air aperture in the surgical suite at the top, right?
Still had the amphitheater. She still had the amphitheater.
Just to let you know that surgery goes way back in New Orleans in the community there. So going from there, from your residency, which you finished after 5 years as is standard for surgeons, and again, just in the business, we know general surgery residency is very tough. You are going to be working a lot of hours. It's not just the amount of hours that you're working. There's also a mentality of surgeons that are going through there that, I think the old saying was, what's the only problem with Q2 call?
You miss half the cases.
You miss half the cases, yeah. And so there's a certain amount of inbred personality that you have to have of, no, I want to do more, I've got to do more, I want to learn this. Can you speak towards that or talk about how that was?
Back to the practice room, right? When your bassoon professor is asking you why you didn't play this piece well, and you say, well, I messed this up, I was, this, that, or the other, and they say, well, how much did you practice this week? How many hours a day did you practice? Sir, I was practicing about 4 or 5 hours a day. To which my bassoon professor, well, there's 24. Yeah. And so there's overlap here, right?
Yes.
That determination to the nth degree to really know your craft.
Yeah.
And at LSU, it was told to us all the time, you have 60 months.
Yes.
You have 60 months to learn this.
Yeah, so true, right?
And this is a finite period. So
we have to get as much of this garden hose in your mouth as possible here, and you better be ready to take as much as you can.
And buckle up.
Yep, yeah.
And there's something to that. I was actually having a conversation with one of the young hospitalists at Bay the other day. And the surgeons, on our service and training, there's no caps on the number of patients you take care of. On the medicine service, there are.
Indeed.
And I posed the question to this very, very young hospitalist, good hospitalist, very young.
Sure.
Have you ever taken care of more than 30 patients at a time? Well, no. How do you know if you can?
That's right.
Well, I wouldn't because we had caps. Exactly. And she made a point of, this is, they're focusing more on resident well-being, which is a whole nother hour. But
we only got so much daylight.
Yeah, exactly. My counterpoint was, abuse is wrong, right? Sleep deprivation to the point of critical errors that harm patients is wrong.
Yes.
But I have taken care of 60 patients at once by myself in a protected environment in which I had more senior people looking over me and making double checking things. And so I know where those limits are.
Yes.
And I think there's a happy medium between, 200 hours a week, 170 hours, whatever, living in the hospital.
Of course.
And, go home after 40 hours. And, so there's a happy medium in there.
Well, it also comes, when you come out into practice, there's not necessarily going to be patient limits that you're going to be afforded.
Yes.
And, when you talk to some of the people, so for example, my brother-in-law, he's a surgeon, and he trained before there were hour limits. And, he said, I'm concerned that you're going to get the training that you need whenever you come out with that. Because the truth is that when you have infinite time and infinite resources to make decisions, yes, you tend to make the right one. What's hard to do is you've got 2 minutes and it's 3 a.m. and you just got woken up from a dead sleep.
Right.
What are you going to do? How are you going to think about this? How are you going to crystallize that thought? And how are you going to give the best care to the patient? Mm-hmm. That's a different experience. And you really only get that by trial by fire.
Yeah, and by doing it.
By doing it. You got to do it.
And doing
and you got to make mistakes
in
too.
But those mistakes with a safety net.
Yes.
Right.
Yes.
If you right now, my safety net is my partner, and I don't wish to utilize that safety net.
No, you don't.
In training, those 60 months, I have a built-in safety net.
That's right.
And yes, you may be chastised for a mistake, or my attending, looks at me, Dr. Johnson, why, did Miss Smith do something to you? Because did she offend you in some way? Because you're trying to kill her, right? So things like that, right?
My attending said much worse things. I just want you to know there was totally different language used, but.
So those learning in that environment, yes, it's hard. Yes, it's tough. But it's because the stakes are so high.
It is. And then no better way to learn that this is really important. And you've got to do the right thing at the right time. Yeah. So now, moving on to your fellowship. Tell us what you did your fellowship in.
So my fellowship is colloquially termed MIS, which is minimally invasive surgery. The full name is Advanced Gastrointestinal and Minimally Invasive Surgery. That really doesn't fit on a business card very well.
No.
The world of minimally invasive surgery, to give you 5 minutes on, it was developed in a response to the advancement in technologies with doing big surgery through small holes.
Yes.
The first laparoscopic cholecystectomy was done in 1987. The vast majority of the surgeries and the techniques that I use today, not necessarily the surgery itself, but the techniques that I use did not exist 30 years ago. In their current iteration, they did not exist, which is fascinating.
That ever-accelerating pace is just fascinating when you think about it.
But minimally invasive surgery actually came from the private sector. It was surgeons who were not employed at the university where time doesn't matter, where you're teaching, you're supposed to be taking all this time. It was surgeons who were out in the community who were saying, hey, I have a finite amount of time to perform a finite number of cases. These patients recover better. They get out of the hospital quicker. I don't have to round on them.
Yes.
Their complications as far as wound infections, hernias, they're lower. This can help me be more efficient. And that was kind of the start of
the genesis of
MIS.
this idea.
And you're still doing the same surgery.
You still have to get the gallbladder out.
Right.
Yes.
It's a different view. And we actually saw this, the incidence of common bile duct injuries when we first started taking out gallbladders laparoscopically actually went up. We hurt more common bile ducts minimally invasively than open.
It's a local minima there that you have to get over that in order to get to much more global.
And now
minima.
we're much better. And that was actually an argument against minimally invasive surgery early on.
Yes.
Was why this common bile duct injury, which if you for our members that aren't familiar with common bile duct injuries, you take 5 years off a patient's life with a common bile duct injury. 5 years off the top.
Just one nick. One nick.
And so there was it's interesting to me to go back and read the articles and the editorials from the early 90s about this, when there was a legitimate argument of whether we should be doing this procedure. Now, if you came in to see me and I said, I'm going to do your gallbladder open, that is so far beyond the standard of care. It's not even funny. Now it's robotic versus laparoscopic.
Yes.
And we're kind of retreading the whole robotic versus laparoscopic discussion now. But all that to say, minimally invasive surgery actually did not come from the university systems. It came out of these private hospitals and private groups. And where I trained in Baton Rouge was their fellowship started. I think I was the 15th fellow. So we're talking late 90s, early 2000s is when they got started, which is really when a lot of your minimally invasive approaches had gotten through that awkward, those awkward early teenage years and were really starting to come into their own. and the guy I trained with was it was a big group of 8 surgeons. The program director is a guy named Carl LeBlanc, who
very Louisiana name.
Yeah,
yes,
right.
Love it.
Carl's a wonderful man. Also a polymath. He has a woodworking shop. It's
as you do.
Fascinating.
Yes.
But he did the first laparoscopic ventral hernia repair ever back in '93. So
did you ask him about this procedure?
Oh, we've talked about this.
Is he shaking hands? I mean, like to kind of.
He is. Carl knows his contributions to the medical world.
He's willing to talk to you about them?
He is.
Okay.
And he's got this wonderful personality about him where he has, like, he knows what he's contributed. But when I was there too, he was at a point in his career where he was very sure of himself, but also knew that things were progressing. Right?
Yeah.
And he'd always get the interns when they were talking about recurrence rates with hernias. You ask, this particular type of hernia, what is the recurrence rate? Oh, it's 7%, whatever. And he'd always look at him and say, well, what's my recurrence rate? So you're an intern, you're scared of this man.
Of course.
And so you don't know what to say. And invariably he will look at you and go, well, what is it? Give me an answer. No one likes an indecisive surgeon. And you say, oh, it's 2%.
Is it 7%?
To which you would then go, are you saying that I've had a recurrence? That I, Carl LeBlanc, have had a hernia recurrence? What are you saying? That was
of course, it's hazing. Yeah.
And of course he's had recurrences. But yeah, it was a great experience because you name a weird hernia, we had seen it.
Of course.
And how to fix it. And one of the neat things about him being kind of on the very forefront of this sort of repair, he was always thinking of, hey, can we do this better? He's contributed not just with his literature, he's worked on tackers and staplers and mesh development and all the kind of nitty gritty of the hernia world.
Those guys that you hear about that had that curiosity that said, man, what if I had a right-handed screw for those kind of people really they push the fields far forward.
He did that all the time.
Yeah.
And he's a very good teacher. The other guys in the group, they were a multi-specialty group. So we had guys doing bariatrics, we had guys doing surgical oncology, the whole gambit of minimally invasive general surgery. And we trained with them as residents. So when I had started my fellowship, I had already been with those guys for 5 years.
Yes.
So there wasn't that awkward break-in period. They were just kind of like, okay, go do the colon. I'll see you in a couple hours. Which was great because it allowed me to kind of get a few extra months of, responsibility.
Flap your wings a little bit before you're too far outside of the nest. Yeah,
exactly.
that was really important.
But it was a great program, and we were doing everything. I mentioned Dr. Lyons and Dr. Tabor. Yes. We were doing robotic livers, robotic Whipples, robotic esophagectomy. These
robotic Whipples seems like that's science fiction. Whenever the lay doctor hears about that kind of thing, but that's really fascinating.
It's a beautiful procedure. But
only a surgeon musician would say it's a beautiful procedure. I just want to say that for the record's sake.
It truly is. Yeah. And the other nice thing about being able to train there with those guys who at this point in my life were becoming my friends.
Of course.
They had
colleagues.
Colleagues that, learning to call your attendings by their first name is always difficult.
There's a little trepidation whenever you first do that, but then...
They had seen me come up, from an intern, and, they saw I have pictures of my attendings holding my child in the surgeon's lounge with his little scrub cap on because, babysitters are expensive.
Yes, they are.
And when you're a broke resident... And
you've got surge techs that can take care of that.
Well, when you and your wife are on call, the baby's got to go somewhere. So,
that is right.
So yeah, and they were a great group of guys. Dr. Hausman, Dr. Rhines, Dr. Alland, Dr. Klein-Peter, all these guys. I still talk to them every so often. I actually just saw Dr. Hausman at a medical conference 2 weeks ago. Oh. And so they're really, really good folks.
Well, so Now, you would bill yourself as a foregut surgeon. Is
Yes.
that correct?
Yes.
Okay. Now, I obviously know what foregut is,
Right.
but why don't you explain it to everybody because I have no idea what it is.
So, in the world of minimally invasive surgery, there's a lot of kind of subgenre, if you will, just like in the world of
Of
cardiology.
course.
You have
Of
your
course.
electrophysiologists, and your invasive guys, your diagnostic
It's a
guys.
lot of levels of pretension. There you go. So, yeah, it's just-
In MIS, you have folks that will focus on bariatrics. You can have people that do like advanced endoscopy.
Yeah.
You can have people that are doing more MIS oncology type things.
Mm-hmm.
Foregut, technically speaking, is anything above the ligament of Treitz.
Okay.
I found an interest in foregut for a number of different reasons. And if you tell someone you're a foregut surgeon now in 2025, what that typically means is you're a field expert in esophagus, stomach, duodenum,
Yes.
and disorders thereof.
Yes.
Pancreas and liver, there's a lot of overlap with surgical oncology
Has to
and benign versus malignant disease. But as a foregut surgeon, the things that I'm typically treating are disorders of motility, disorders of mechanics, and functional disorders of the esophagus, stomach, and duodenum. I find it interesting. One, because minimally invasive surgery was made for the foregut.
Said like a true foregut surgeon.
Right. Those surgeons in the audience that have ever done open bariatric surgery or open foregut surgery, it's not in a very pleasant place.
No,
you're talking about the size of a grapefruit, right behind the xiphoid process.
There's a few different other structures around there.
It's some high-priced real estate, and getting there open is relatively difficult. So instead of working right there, I make incisions lower and can look from the bottom and get, I can work up into the chest from the belly, which is a very nice thing, and I don't have to make a thoracotomy. So
well, I've spoken with you about this personally before, but the time difference. You would think the general knowledge is open, I can get in there, I can fix it, I can get out. Whereas minimally invasive is going to take more time, I've got to insufflate, I've got to get holes, I've got to get all these other things. Could you maybe talk towards
absolutely. So there's a misconception that gaining access to the abdomen is a laborious and time-intensive process minimally invasively. It is until you get over that learning curve, that
Yes.
Once you do it, and once you have a team that knows your steps, right? When you're working with a good orchestra, conductor comes up, steps on the podium, everyone scoots to the front of their seat, they're watching, they're waiting for that first downbeat. The OR, I don't have to talk that much. Walk in, hey, we know everybody, let's go. I'm holding out my hand for the next instrument. They know the dance.
Yes.
Now, getting to that point is laborious, but it's worth it. And so with that well-oiled team, getting in and out of the belly is much more straightforward. And then the surgeon that showed me that gallbladder back in college in Crestview, David Herf. One of the things I asked, what should I look out for? One of the things, and I didn't think it was much at the time, but now he's like, I operate with the same people day in and day out. Get a good team.
This is it.
He was exactly right.
Yeah. Is there anything better than an awesome tech in your cases? And is there anything worse than a bad tech?
Yes.
Those things. And here's the thing. It's because, whenever you are in the middle of these surgeries, whenever we're in the middle of procedures, it really is a flow state. You're moving here, you're looking there, you're hearing the sounds, you're doing all the things, but you're almost not thinking about it. It really is like a symphony. Now, if something goes wrong, if this wire feels different, if this instrument feels different, that takes you out and you have to say, wait a second, that's not how this typically happens. And then you've got to rethink about it. But otherwise, it's just flowing. Your hands just go in the right direction, in the right place, and do the right thing.
And working with the same people for a long time, you develop that.
Yes. And
all ORs are different. If you ever, the good Dr. Moody's operating room and my operating room are a little,
your wife.
A little different.
Yes.
Allie. Mine's a little more pell-mell.
Okay.
I have a lot of students. I have a lot of people in and out. But with my team, this has happened before. I can change the tone of my voice, and they'll know. Hey, let's turn the music down. Right. Hey, let's open this other instrument. Hey,
that's exactly right.
This happened a few weeks ago actually. You have a little bit of bleeding from one of the phrenic veins, and normally a little pressure, no big deal. I had a little more than normal, and I slowed down. Like my pace had changed a little bit.
Yes.
And I said to my scrub tech, I was like, hey, I think we're gonna need to open some we call them doobies in the OR. They're rolled up Raytech gauzes.
Good. I was thinking something totally different. Okay, good.
So
now's not the time, Dr. Johnson, but okay, all right.
Open some doobies, and God bless her, she goes, Dr. Johnson, I already opened them. And it made me proud, because this is someone who is a good scrub tech, but
that's right.
has continued to improve.
Yes.
And work with me and know, and it's not a me thing, right? It's that she's a good scrub tech there. She's a good scrub tech in, Dr. Balazzi's room, Dr. Bagoli's room, Dr. Castellucci's room. She's just a good scrub tech.
Yes.
Because there's that attention to detail. Just like the attention to the notes in a symphony, just like the attention to anatomy, that person shares that level of attention to detail. And it's beautiful when you're surrounded by folks like that.
Boy, it makes everything better, right?
Oh, yes, absolutely.
It also testifies to the things that we do really are a team. There's not any one of us that is doing this. We have to have an entire group of people behind us that are in support, that help to make all the things that we do. Sometimes we get a lot of the FaceTime. What I've always said to our EMS colleagues is that together with you guys, we have saved a lot of heart attacks. We have absolutely done that, and I will give them credit every single time that I get the chance. I'm going to keep the money, but I will now.
Well, so one of the things, that being efficient with with getting in and doing these surgeries, you don't have to take as much time. And when as those scrub techs are learning these kind of rote things, sometimes it can become stale, right? Yes. Sometimes the dance gets a little stale. One of the things I don't know who I stole this from, but I'm sure it wasn't an original idea. I like to give them updates.
Yes.
Hey, that disaster case we did on Thursday, they're doing well. Right.
It's buy-in.
Yeah. And those people that just work in the OR, they don't get that FaceTime like you were saying,
That's
right? Like they don't get that feedback. I love my post-op clinic because I get to say, hey, you don't have stomach cancer anymore. Or I get to talk to this made me cry when I saw this lady. 91-year-old lady, demented, not completely bedbound, but really didn't get out of the house much. A lot of other medical problems. And she had a horrible type 4 paraesophageal hernia. She had all of her stomach and part of her colon up in her chest. And her day-to-day...
That's not where it belongs at all.
That's not where it belongs. No. That's the good Lord put it in a slightly lower.
Its own place, yes.
All she did all day was lay on the couch with a garbage can next to her. And...
It's not much of a life.
No, it's not. And no one wanted to operate on her because she looked like Moses' godmother. And
the eyeball test was a little bit low on that one.
Right.
Yeah.
And I remember talking with her, and her niece was her caregiver, and she was just miserable, and she was in and out of the hospital for dehydration, for aspirations, and she was an extraordinarily high surgical risk. Like this lady may not come off the ventilator. And I remember talking with her niece, and they're just like, what do we do? Do we do hospice? Do we can you help? And I went back and forth on it. Should I do that? And there's all these things in the back of our head, right?
Of course.
Potential litigation. This is an optimal candidate.
Of course.
I'm young in my career. Is this am I gonna develop? All these insecurities and arguing angels on your shoulders, right?
And you don't want to be 4 hours into this procedure going, what did I get myself into? Yes.
Right. And so I talking with the family and using, shared decision making, we went to the OR. And I fixed her. And she lived 6 months. She died 6 months later. Which in the surgery world is horrifying because I don't want a surgery to be associated with the end of your life.
Of course.
Right? And there's a whole role for palliative surgery. That's a whole different discussion. Sure. But something like this, which is generally elective, that the optics on that aren't all that great. And before surgery, I asked this lady, what do you, we're getting an idea about diet, what do you eat, what do you enjoy? And she loved Whataburger hamburgers. And she's like, I
at least get the breakfast on a bun if you're going to do it. I mean, I don't know why the hamburgers, but either way, yes.
I just want to eat a Whataburger hamburger.
Yeah.
And I'm like, okay, well, you're going to be on a special diet after this. You're not going to be able to eat that sort of stuff. And honestly, with a big hiatal hernia and your esophageal dysfunction, breads and compacted sandwiches probably aren't going to be the best for you, but let's see.
Yeah.
And 6 months later, when I talked to her niece actually called my clinic and let her know that she had passed away. And when I talked to her, I was like, "Hey, how was she doing? Was she doing good? Because I'd seen her in follow up, and then hadn't seen her for a number of months." And she goes, "Yeah, Dr. Johnson, she was eating a Whataburger hamburger about once a week." Oh, man. And it killed me. And
yeah.
I had the privilege of telling my OR staff that story,
yes,
who busted their ass getting that lady through surgery and getting her to have that hamburger. And when you have people that understand the weight of that, the privilege it is to work on somebody like that, they get it. And it's easier to show them that when you can tell them those stories, because they don't have that privilege like you and I have.
Absolutely.
Right? They don't get to see that follow-up visit.
That's right.
And so I try to share that with them every so often. I think that plays a role in folks enjoying my OR.
Beautiful story, really moving, and just a testament to the services that you provide to our community. But also, my goal here, why I'm in cardiology in the first place, is because I want to empower patients to get more meaning in their lives. Mm-hmm. And when they feel terribly, they're not getting a whole lot of meaning because they're so busy feeling terribly. And as strange as it may sound, that Whataburger was more meaning in their life. I'm not here to tell you what the meaning should be. Right, I'm here to try and get you to where you can have that. So good on you for practicing what you preach here and doing the right thing. Yeah. Let's change.
Yeah.
Tell me about the future. What does the future hold for surgery? I want 100% accurate answers here. Okay, zero speculation.
Surgery in general. Well, surgery in general is one thing. Surgery in my world is another.
Yeah.
Surgery in general is interesting because I think, and this is there's about 1 million doctors in the U.S., roughly, give or take. There's about 1,000 graduating chief residents in surgery every year. There are estimates that we're somewhere between 10 to 15,000 general surgeons behind. And the more specialized we become, I am concerned that we're going to have a reversal back to there's only one place to get your heart transplanted.
Yes.
Right?
Yes.
That's why Allie and I came here, is because I don't. This is my active way of trying to do what Halstead wanted us to do, which was go to the university and take it out to mass.
That's right.
I think if we can work on the democratization of those subspecialties, vis-a-vis virtual call.
Yes.
Let's say I am the area expert in foregut surgery.
I could say that with some confidence.
In 30 years. I'll be
okay,
the old
when you get
area expert.
Exactly.
I'm on call for the Panhandle of Florida.
Yes.
for a virtual foregut call, where I can, much like our radiology colleagues can have a reading room in their home. Mm-hmm. I hear that's can be done.
I hear tell.
I hear tell. I can have a console.
Yes.
In my home or in my office, a remote location. Where I can zoom in, if you will, telemedicine into a surgery where a surgeon is having a particular question about a step or a technique or decision to do this, that, or the other, and provide expert services to this person in Bunkie, Louisiana.
Yes.
Hey, and even here, I have patients that drive from Bonifay and Chipley and Dothan, all around. Hey, you don't have to necessarily come here. They got a platform that is capable of handling this in Bonifay, and a surgeon that's willing to do it. We can have expert level coverage there. If there's a guy in Arizona that can drop bombs in Afghanistan,
which there is,
I think we can figure that out.
We can do this.
That's exciting to me because it takes the expertise that you get from a university setting and talking with your colleagues and puts it accessible to those of us that are out in the world. And so it blurs the line between this, academic ivory tower surgeon and, the grunt in the trenches.
That's right.
Out in the world. And I think that when we take those lines and blur them, where I can appreciate the contributions of the person in the ivory tower, and the ivory tower knows that they can't be there without the person in the trenches.
That's it.
It elevates care.
Look, I've said this for a long time, is that, my academic colleagues would have a difficult time working private practice, and vice versa.
Absolutely.
It's different aspects, but I love this idea of smoothing over to where you just have everywhere is a tertiary referral center. Yeah, we're just able to do this at all places. Now, you had kind of alluded to it, but what I was kind of sneaking up on is robotic surgery.
Yes.
You doing robotic surgery 100 miles away in Chipley while you're in the comfort of your home. With your kids around, throwing things at you. Is that on deck? Is that coming in the future? Is that going to be something that we can certainly, not science fiction, but more science fact?
Yes.
Okay.
That is, we're already doing remote case observations. So I can, let's say I'm on the learning curve for a new hernia repair technique. Okay. I can call Intuitive or Gore and say, hey, I'd like a video proctor for this case. Okay, Doc, let's get it set up. And I can have someone zoom into my case. They can't take control.
Yes.
But they can observe the case. They can discuss things just like an in-person proctor would.
Yes.
Right? I proctor for the robot. I help teach the robot to other surgeons. That's a day and a half, 2 days of my time that I'm not doing clinic. I'm away from my kids. I'm away from my family to go and teach, which is a good thing. But the logistics are hard. So we're already adjusted, and that's only been in the last 2 or 3 years.
Well, and maybe we could just give a quick recap of how robotic surgery works here. Are you using a remote controller here that's causing a robot to walk up to the patient? It's perhaps a little bit different for those that aren't familiar.
Yeah. So robotic surgery has so many implications, and it's I
some
feel
of them
like,
are even true.
I feel like I'm a translator a lot of the times because if you say robotic surgery to the person in the high rise versus the person that cleans the high rise, you're going to have two different interpretations.
That's right.
Even in our world, if I say robotic surgery to an orthopedic surgeon, they're probably going to be thinking about like robotic knee surgery, but there is a lot of the work being done in conjunction with the robot. Now, the robotic platform that I use and most of those spin-offs of the Da Vinci robot, there's an open. We're coming up on the robot wars because there's
exactly.
The
patents going to be a T1000.
Yes. Lots of different names in the game now, and the platform itself is. That's why we say robotic assisted. It enhances me, right? I would like to think I have relatively good hearing and eyes and hand control, but I don't have 10 times magnification.
That's right.
I have that on the robot.
Yes.
I don't have the degree of articulation that the robot has. The robot wristed arms actually have more articulation than the human wrist.
Yes.
And
further degrees of freedom. There.
Exactly.
Yes, yeah.
I'm able to do things with the robot that I physically am incapable of doing.
Retraction must be much easier in the robot.
And I'm my own retractor. And I'm holding my own camera. I don't have a sleepy scrub tech that's had 3 cups of coffee that's shaking the camera.
Exactly.
You can't see. So it's robotic assisted. So I'm sitting at a console with looking through a viewer, manipulating instruments.
Yeah, and just to be clear, not at the bedside.
Not at the bedside.
You
No.
are you're maybe you in a
off to
separate
the side.
room. Yes,
Yeah.
off to the side
Off
over
to the
there. So I think that's kind of a fascinating thing that is going on here, and again, going to really improve outcomes. I think, especially for more rural areas, as this kind of becomes,
Absolutely.
like I said, a little bit more science fact.
Yes, I think it's going to extend longevity of surgeons.
Yes.
I think
But there are some good things.
Yeah.
So just kidding. So is it?
Yes, it's so. When you look at in your world, cardiothoracic surgeons.
Yes.
How many of them have neck surgery because of sitting?
Oh, yes.
I sit all day. I feel bad about it. When I talk with Allie, Allie's a breast surgeon, so she's doing. I mean, these are open cases. She's lifting up under the pec. They're very physically demanding.
Very physical. Yeah,
very
that's
physically
hard to do.
demanding. I sit down in a dark room, and
I was hanging out listening to a podcast. I don't know.
right? Yeah, so, and so it's gonna help with longevity, as far as like the technical aspects, the ergonomics. It's going to be better. And for me too, it allows me to do a much longer case.
Yes.
With less fatigue.
Yes.
Which you can't. I don't care what if a surgeon says they are the same at the beginning and the end of a 6-hour case. They are wrong.
Yes, exactly.
That's not how physiology works.
How do you know they're lying? Yes. That's right.
But it lets you, give you a little more run, more gas in your tank, if you will.
You'd prefer me to be reading your echo earlier in the day than later in the day, okay?
Right.
So now, apropos to that, tell me how you think about AI.
Fascinating discussion. So
there is.
I'm going to answer that different ways. I'm going to answer that with a very small anecdote, but we're getting to AI. I was just at a conference a couple weeks ago, the American Foregut Society. American Foregut Society is a fascinating group of people. It's a bunch
You
of
just said nerds, is what I heard. Okay,
bunch of nerds,
Yes.
just like me. And,
Peas in a pod.
Allie laughs at me all the time. She's like, you found your people with me. Like this is your thing. Like, yeah, it's great. I love it.
It is. Yes.
And I love you so much. I'll see you in 4 days. But the whole premise of the American Foregut Society, and if our members don't know the American Foregut Society, there's a website. Go at it, look at it. There's a ton that I like about it. One of the things I really like, and one of the things that's unique about the American Foregut Society, you're a member of the American Cardiology Society.
College of Cardiology.
American
Yes.
College of Cardiology. They have an annual meeting every year, right?
Indeed, they do.
Who goes to that meeting?
Lots of cardiologists.
Cardiologists.
Yes.
I'm a fellow of the American College of Surgeons.
Yes.
The American College of Surgeons has a meeting. Who goes to that meeting?
Surgeons.
Surgeons.
Yes.
American Foregut Society is not surgeons. It's not medicine doctors. It's both. It's about 50-50 gastroenterologists and surgeons, all of whom have a passion for working on this one area of the body and all the interwoven multidisciplinary things that go into that, right? You do any sort of oncologic care. What does it say? Multidisciplinary review. Multidisciplinary.
Yes.
Even in your oncologic societies, you have the Society of Surgical Oncology, and you have, American College of Oncology. They're not actually multidisciplinary.
They're not.
This is a society that, from its beginning, 5 years ago, 6 years ago, is designed to be multidisciplinary. So you've got surgeons and GI doctors coming together and thinking and talking. And one of the things we talked about this year was AI. It was great.
Yes,
Fantastic.
yes, of course.
And there's a lot of work being done on AI within the world of polyp detection and colonoscopy. This has been something that's been looked at. And one of the challenges, allow me to be a nerd for a moment.
Go for it.
One of the challenges in esophageal cancer care is early detection. We know there are certain risk factors, and we know that those risk factors tend to lead to screening, but some of those risk factors really don't correlate. So, like, everyone hears, oh, if I have heartburn, you're at increased risk for esophageal cancer.
Not 100%, yes. It's
40% of patients with esophageal cancer never have heartburn a day in their life. And so we're catching the 60, but 40% is a whole heck of a lot of people. And even when we do endoscopy, some of those, early precancerous changes, we don't see with naked eye.
With our eyes,
you have to have narrowband imaging, a chromoendoscopy, which is not done everywhere. Or people aren't doing enough of it to really recognize some of that. So you take 15,000 images of Barrett's esophagus and you feed it to an AI, and then you have that brain kind of looking over your shoulder and saying, hey, maybe you should look at this place a little more closely.
And you don't even know what it's looking at that it found, but there's something that it's iterated upon that it can say, this is the thing.
I think that's the goal. You hear all the hyperbole of, AI is going to take our jobs, and AI is going to, you're just going to, feed symptoms to a computer and it's going to tell you what's wrong. I think that's a little, I love dystopian fiction, but I think that's a little dystopian.
Yes.
I think AI enhanced, just like robot assisted.
This is it.
I think AI enhanced is what we're going to be looking at.
Yes, yeah. The analogy that I had always had is of chess. Deep Blue and other chess playing software now can beat our best humans by a bunch.
Right.
But still, human computer hybrids beat the chess
Exactly.
computers. And
Exactly.
so I think there's going to be a long tail of hybridization where we are utilizing this technology to our benefit.
And I think one of the things I like about AFS is you have the gastroenterologist sitting there saying, hey, we're doing 20 endoscopies in a morning. We're trying to turn and burn. We need this to tell us to slow down. And then you have the surgeon sitting there going, hey, I would like to point out that when you look at surgical procedures, your complication rate actually increases in your second 100.
That's fascinating.
Because you get complacent.
Yes.
And so this is
a
good
tale
that
of hubris there.
This thing is looking over your shoulder,
That's
but
right.
What are we going to do to make sure we don't get complacent? What are we going to do to make sure, the AI is looking at it, I don't have to pay as much attention? That notion, if you just had a room of gastroenterologists without the surgeon saying, hey, maybe we should back up on this, you wouldn't have that other perspective. And if you just had a room of surgeons, they'd just be dumping on the gastroenterologist for, they're being lazy and letting the AI do it. But instead, you have these two perspectives, and the outcome of this discussion was all of us going, I think there's advantages to AI, but I have to guard against relying on it too much and think about that. So it was a beautiful thing.
That's a really fascinating discussion and wonderful insight. That's why I love to have different subspecialists that can talk about how AI is going to enter into their world, because I never would have known any of that. Now, one just quick physiologic question here. You said that 40% of the patients that end up getting esophageal cancer do not have any reflux type symptoms subjectively. Are they still definitely having reflux? Do you have to have reflux as a progenitor for esophageal cancer? Did I just ask a good question?
You asked a good question.
Mark this down. This is amazing. I never would have thought that.
So the short answer is we don't know.
Okay.
The silent reflux and laryngopharyngeal reflux and all of these things are that's another hour.
It's like silent angina. Yeah.
Right. Yes. So we know that those patients that don't have your typical reflux symptoms can still have exposure of acid to the lower esophagus that can lead to mucosal damage that can ultimately lead to cancer. I also think as we learn more about some of these genetic syndromes and some of these, markers of, if you do any genetic tests, you get these markers of certain significance. We're going to learn those significances.
Yes.
And so they are having some degree of reflux, and that's part of what I do is quelling fears about that. And if you look at the overall numbers, right, the incidence of actually getting esophageal cancer is remarkably low. Now, it's gone up exponentially in the last 40 years, something like a few 100% increase. It's
This is
very, very
environmental exposure?
we think largely of Western diet, obesity associated with reflux, things of that nature. And we're seeing much more adenocarcinoma as opposed to squamous cell. Squamous cell typically being associated more with your smoking and things of that nature. But what we don't know, and the interesting thing to my mind, is those patients that are physiologically having reflux, but they don't have the reflux phenotype.
Yes.
They have acid exposure.
Yes.
We can do pH testing and see that.
Yes.
They don't feel it. Why? Or those patients that have, and I'm probably going to give some GI doctors PTSD, functional heartburn.
Yes.
Which you want to see some GI doctors
Oh,
argue.
they're already tachycardic.
It's lovely.
It's downstream revenue for me.
Right. Functional heartburn. Those patients that have the phenotype of retrosternal burning, but have normal pH. What are their esophageal cancer risks? We don't know.
We don't know.
Which is another reason why I like foregut surgery. So there's a lot of things we don't know and a lot of things we're learning. But that's a long way of answering your question of most likely those people that are not experiencing heartburn are refluxing in some way. They're having some degree
there has
of
to be some
damage.
insult of that of that endothelial layer. Or,
and whether it's on
layer.
top of a predisposition for whatever reason, your any of your genetic predispositions, we don't really know why that phenotypic change is there, like why those folks don't.
Look, this is where I think AI is really going to start to come in, is because we're going to not only get the genomic perspective, we're going to get the proteomic perspective about where these different proteomic changes are going to cause different exons creating different protein kind of phenotypes, if you will, that end up causing, there's too much data there. There's too many variables for us to be able to get our human brains around it. But AI might be able to put some compute there.
It's going to show it's going to allow you to do the large volume pattern recognition.
That's it. That's what it's great at.
That you only, all these things, the medical mistakes, right?
Yes.
How do we come up with lactated ringers? They stopped using distilled water because he forgot to buy distilled water. He had to use tap water, right? It's things like this, right? And I think you'll be able to, instead of having to stumble on something like that, and if you really want to nerd out about random chance models, if you have enough people with enough labs running you're going to run across these things. But I think with AI, you're going to be able to run enough models, large volume pattern recognition, that then spurs further inquiry.
This is it.
Right.
And it kind of harkens back to how we started this conversation with you being a musician and an artist. So part of the time, it's, you can run the iterative process of doing the scientific method, but really your inspiration to try something new takes some special insight that I think is more art than science. I think that you have to kind of think about, well, what if cancer could be caused by a bacteria? Like you have to have that kind of eureka moment in order to be able to do that. And maybe AI can facilitate that, but I think there's some better things that are still coming from us humans as well.
Yeah, absolutely. And I think I tell my patients all the time when they're like, "Oh, the robot's doing my surgery. You're not going to." No, this isn't Terminator yet.
No, not yet. Exactly. I'm going to be sleeping in the next room.
Yeah,
I mean, right there.
I think we're quelling some of the hyperbolic notions of what robots are doing.
That's right.
I honestly think I talk a lot about expectations in my clinic. And what I typically tell people is, just like I tell my wife, you should lower your expectations.
She knows.
If your expectations are low, you'll never be disappointed.
Exactly, that's right.
I think there is a disparity between what a lot of our patients think we are capable of and what we actually are.
That's right.
And I think the more we can bring that to realistic goals and expectations, one, I think we have happier patients. Two, we are happier because, we don't have patients back in our office saying, oh, well, you did this fancy robotic surgery, my hernia recurred. What the heck? Well, if you remember, we talked about, your weight and your diabetes and things like that. So, yes, there was an increased risk with you, but hey, let's see how we're going to fix it now. So I think it makes those discussions easier. But I think managing patients' expectations
Yes.
of what we are capable of and what AI is capable of is going to be hard. It's
going to be more conversation that we're going to have.
Yeah, because this democratizes everything, and so we have a patient that can read an article that says AI just did a nephrectomy.
Yes.
Why am I coming to you?
Yes.
And so I think that's going to be challenging in the next decade or so as AI becomes more expected.
Yes, and I think just having the relationship, and if there's anything that I could talk to myself about, it's making sure in hindsight that you keep that fundamental relationship with the patient. You're looking them in the eye, you're talking to them truthfully, you're establishing that rapport. That's the thing that is going to be hard to replace over a long period of time, I think.
Well, and
I could be wrong.
I think you're exactly right, and to wit, one of the things that I'm proud of in my clinic, there's a few things I'm proud of. I'm proud that I seem to keep Dr. Moody interested. My boys are wonderful, and my OR playlist is just fantastic.
Banging, right?
But right after all of that,
yes.
In my clinic, I do not have a computer in the exam room.
Yes,
I do have a scribe that helps with some of the logistic stuff, but I look you in the face, and I have a pen and a piece of paper.
Yeah.
And I have gotten so much good feedback from that.
Yes.
Of, hey, you actually listened to me. You actually talked to me. And I understand, back to my dad with primary care. Sometimes you can't.
Yes.
He doesn't have a scribe.
Of course.
He's his own scribe. But anything we can do to get this out of that room.
Yes.
Right? Because when you're talking to that patient that's had a horrible MI that is not, you can't intervene on. When I'm talking to the patient that's recurred their gastric cancer and is going to be going for palliative chemo, they don't care if I got my note done on time.
Sure.
They don't care if, they get a note quickly. What they care about is if you're sitting there and talking to them and they feel like they can trust you.
Yeah. Forget about the pathology.
No.
I just lost my husband in 52 years.
Right.
I mean, that's a moment where we need to just sit
you need to be human.
talk about that.
You need to be human.
I mean, that's not something to blow past.
No. And it's more important for you to sit there and look them in the face and say, I'm sorry. Tell me about your husband.
Of course.
Than to document patient experiencing acute grief reaction,
Yes.
secondary to
Review of systems.
You get to
Yes.
that. But being able to have that human interaction and not be the cold empiricist, right? To not be the, solely person of science. This I have to be objective so I can actually take care of patients.
Yeah.
Well, I think that underestimates patients and overestimates doctors because we're all going to be patients.
Indeed.
A lot of us already have been.
Indeed.
And I know that the times that I have spoken to a doctor and they've looked at me and talked with me and can give a damn about the computer, pardon my French, but that's what I think about it. That's who you trust. And I know that doesn't work for everybody. I know there's the business of medicine, and you got to get through the day.
Yes, it's competing interests. You're not
understand.
incentivized to do that. That's for true.
But I have gotten more, return on investment from that, having quite literally a steno pad and a pen, than I have on any sort of AI. Yes. Robot or computer or anything like that.
That's for me. I'll often say that, most of us know what we want to do probably in the first minute. The rest of the time is getting you to trust me that I'm here for you. And that takes more time, and it's worth it. It's worth it.
Absolutely is.
So now, first of all, thank you being so generous. Thank you for your time here. But I just want to ask a few things, some rapid fires here, just to close out here. So who's the smartest person in history?
Oh, man.
You can't say your wife. I'm not gonna have it.
She ain't dead yet.
No.
So, smartest person in history.
Yes.
I'm gonna Plato,
Okay.
because he wrote down what his teachers said. Socrates never wrote anything.
That's right.
We have nothing from Socrates. Without Plato recognizing, hey, there's something here, the basis of Western philosophy would be lost to us.
What a tremendous answer. That's much better than what I had. If we can live to be 1,000, should we do it?
What's your functional status? What's your functional age?
That's it. Again, you're hoping that you continue to be functional.
Yes. Because if we have learned to extend life to 1,000, I think it's a reasonable logical assumption that we have also learned ways in which to extend functionality, accommodate those functional statuses. So,
This is something that was covered with the Hyperion Cantos, by the way.
I know.
Now, too cold or too hot at night?
Too cold. Always too cold.
Good answer. What's one thing you would tell yourself if you could right as you started med school?
Make sure I return Dr. Moody's cup to her.
It worked out okay for you.
I want to make the same mistake twice.
There you go. What is one current medical treatment or therapy we're going to shudder that we used 15 years from now?
Ooh, I like this. No, she'd leave me if I said that. Allie and I have
Same one here.
Allie and I have a running joke about the role of surgery in breast cancer care, and it's on the way out.
Yes.
I don't know 15 years, but it is on the way out. Here's one. Maybe not 10, 15 years, but I do think that we will be able to resect, if you will, remove, destroy, obliterate tumors.
Yes.
Without making an incision.
Yes. I fully see that.
We will do that.
I think that's
there's already work on high frequency ultrasound and liquefaction of solid tumors in solid organs.
Yes.
We're already working on that. And so I think it's Bones in Star Trek is talking about surgeons and the barbarism of cutting someone open. So ultimately, I think I will be relegated to the dustbin of history
here.
So.
All right, one last thing here. What book and or books are you reading right now?
I am currently I've got 2 going. Well, I've got 3. I am reading through The Hobbit with my boys. Oh, so we are.
Great choice.
We just entered Mirkwood, and are looking at spiders. And my boys are about to be 6, 3, and about to be 2. Yeah. And
great kiddos.
The 6 and 3-year-old love it, and the 2-year-old just bounces around. But we're working through The Hobbit. I am finishing H.G. Wells' Time Machine.
Okay.
Which I like. Classic, kind of thought-provoking science fiction, and HG, this was kind of the genesis of that. And so I'm finishing that up. And the other book I'm reading is a little more heady. I'm not familiar with a British essayist named G.K. Chesterton. Fascinating man. I'm currently reading a book called What's Wrong with the World.
Okay.
It was written in, I think, 1916.
Perhaps there's some still resonance
It is
today.
incredibly poignant, and it's fascinating because it's a British man commenting on democracy and republicanism in Britain during the World War I interwar period.
Yeah.
And I think it was actually published in the interwar period, so in the 1920s. But it's fascinating. He talks about public education. He talks about the distractions of modernity and not taking time to think and really spend time with the subject. It really is a fascinating book. Very heady stuff.
That sounds fascinating. It reminds me of I just recently finished Meditations by Marcus Aurelius.
Yes.
And wherein he talks about the frivolity of reading books, saying like, stop reading those books, start to really focus on philosophy and the other things.
Right.
And just, to us, we think reading books is a really august kind of purposeful thing to do, and to him it was just frivolity.
Yes.
So it's anyway, sign of the times. Chris, we could do another 4 hours like this. I would love it. Thank you very much for being in our community. Thank you so much for everything that you do for us. Thank you for being a foregut surgeon that is doing these things here for us, for our families, and I'll keep you on speed dial in case anything ever comes up with my foregut. So
thanks for having me.
Thank you very much for being here, and thank you for being a part of ECMO.
Of course. Good to see you.